Cardiothoracic consultant surgeon in Shifa International Hospital. I've recently moved to Pakistan. My main training was in United Kingdom, and after the training I worked as consultant cardiothoracic, robotic and transplant surgeon in UK and Ireland. I had the privilege to have been awarded the dual national post-CCT funded fellowships at which I did concurrently. It's a very unique award, and I feel honored to tell you about this. It was good to have these talks before me, where we discussed the past, and we also discussed the present, which is the minimally invasive being introduced or already being practiced in Pakistan. And let's see what the future holds for us, in particular for Pakistan. Now, I'm not here to teach you the robotic surgery, and neither am here to justify that robotic surgery should be introduced. I'm gonna rather, after my talk, give you an insight and pose a question towards the audience so they can decide. For the people who don't know or who haven't seen the robotic surgery, it's being done in many centers, both in cardiac as well as in thoracic. There are usually two things. One is called the surgeon console, where you sit and operate, and the second is the patient cart, which has 4 arms, which could be in the same room or a different room. You will have a different scrubbed person who will be your assistant, scrub assistant, or there will be a scrub ready for you just in case if you need to open the case. Now, let's go a little bit into the background. A robot is not new, it has been used for decades, and not only in other specialties, but also in the cardiac surgery itself. The first robotic operation was probably done in the 1990s, so it's been there for more than 2 decades. It has just taken us long to adopt to this technology. And to be honest, there was probably all sorts of operations done with the robot, including the valvular as well as this revascularization. Though in terms of valve, mitral valve, particularly the repair, has been the more popular operation because it has real advantages with the robot. But having said that, people have done air fibrillation, they have done atrial septal defect. Coming to the revascularization, this has been relatively questionable area, as we have heard a few questions before about the mid-cap. Similarly, there are certain limitations due to the volume and due to the experience, and also the technique being difficult. So it's usually limited to either the single vessel disease or when you are planning to do the hybrid. But mitral, no doubt, if you speak to any minimally invasive mitral surgeon, this is great. Whether it is robotic or whether it is video assisted, because you've got mitral looking right in front of you when you approach the right thorax with a smiling face, giving you an opportunity to do whatever you really want to do. And this is where the robot has certainly got the advantage over any other methods. Now, I have been trained in both cardiac and thoracic. I know in Pakistan it's different. We have separate cardiac specialty, we have separate thoracic surgery. If you look at the thoracic surgery, it was recognized as low specialty, and in old times people used to say a failed cardiac surgeon becomes a thoracic surgeon. That was a very popular saying in UK. But things have changed, and the thoracic has recently been really revolutionized because they've gone minimally invasive, although they started at the same time as well in 1990s. I think Paul Walker was the first one doing UK minimally invasive wire surgery in 1990s, but it took him years to really make it popular. But now they have flourished. They've gone from 3-ports VATS to uniportal VATS. And as I said earlier in my talk, they have actually gone out of thorax. Now we're trying to do sub-Z for it. Small incisions, if you want to do bilateral surgery, and at the same time, less pain to the patient. Having said that, what robot has advantage over the VATS? because you can do the same minimally invasive surgery with the VATS with a cheaper cost. That's the advantage it has got. So you go in between. You can do more complex operations. Sewing work is very difficult by doing VATS because of the long shafted instruments. This is best. Segmentectomy. Now, with the advancement and introduction of the lung cancer screening program, people are intending to do lung reservation surgery or lung preservation, lung parenchyma preservation surgery. And in segmentectomy, you really need a good view, which a robot gives you. And also is the Firefly, use of Firefly, which you can see here, where you can highlight the tumors, where you can highlight, like in this particular patient, the lung volume reduction surgery being done. And also, you can do a mediastinal work. So that's what we were talking about. And coming to the robot, there was a lot of resistance from various groups for different valid reasons. That what advantage robot has got over VATS that you want to go onto this pathway because it's quite expensive. It is true it is expensive, but look at the data. Out of no thoracic center having access to the robot, it has gone into the 8 thoracic centers, and it is becoming popular. Robotic lobectomy, they have done the studies and has been found safe and similar efficacy to the VATS. And although there is a higher initial cost in the robot, but there is a way of balancing this, as you can see here. There was a study done and was published in 2020. This was a prospective study for a retrospective database where they actually looked down to the quality of life and the cost. And their analysis really showed that there was no difference. When you look onto the clinical side and the cost side, there was no difference in terms of cancer staging, operative time, or blood loss, and lymph node counting. Having said that, there was a higher operative and post-operative cost to the hospital. Will it be feasible for us in this country to introduce? I don't know the answer to that. But what I can say is it has got comparable outcomes, both in terms of mortality as well as the MACE. As long as we understand there will be high capital investment in the very beginning when we're going to start the program. And not only that, there will be a high maintenance cost because Da Vinci in particular charge you a lot for the maintenance as well as they ask you to use their disposables. And there is also something taught about this is the learning curve, that there is a longer learning curve in minimally invasive surgery, which is true. Now, whether that is true for the robot or the VATS, that's something debatable. Does it have any advantage? Yes, it has advantage. It looks good for the surgeon, but it's clinically good for the surgeon as well to operate because you have got the advanced optics and you have got very sophisticated instruments. Obviously, the perfusion techniques have innovative pathways. And also remember one thing, this is technology. It has been developing, it has developed over decades, and it has only to get better. Are there any advantages for the patients? Of course, yes. You minimize the surgical trauma to the patient, which means the patient has less pain, which means the patient has shorter length of stay in the hospital and faster return to the work, back to the work to contribute to the economy or earning for their family. Not only just the cosmetics, but cosmetic is not really a valid thing for us because I think our poor population and the group of these patients we operate in cardiac surgery, they are relatively elderly patients, but it does have the cosmetic advantages as well. Now, what are the challenges? And one of the challenges that we as surgeons, we are used to the tactile feedback, especially people who have been trained with the open surgeries. And this is their first question, that you lose that tactile feedback which you can get to some extent when you're doing video-assisted mitral, but not in the robot. But my answer is, do we really need that? We have got such good optics. Visualization is such great, and we're not closing our eyes. If you know your anatomy well, then you have got a visual feedback, which probably is more important. Having said that, when in the future the technology improves, we may probably develop that tactile feedback into the robot as well. Longer operative time, yes, it is true. It takes long to set up the robot, and maybe it takes longer to do the same operation. But remember one thing, people used to do open thoracotomy and compare it against the lobectomy because it takes longer, but the VATS lobectomy has turned out to be much quicker than a thoracotomy. And same is true here as well. When you get the expertise, this will be a reflex that you will set up your case and the robot in time and do the operation very quickly, and particularly mitral. So that really is not a valid question. Learning curve. Again, I put really, and the very first speaker has put a very good question at the end of her talk. We have got very good teachers, but she asked, do we have really good trainers? And on top of it, do we really have good mentors? That's what we lack, and that's where the learning curve comes. We need to train our new generation directly onto minimal access. We need to train them on technology. That's how you minimize the learning curve. We don't want the new surgeons to do 20 years of open cardiac surgery and then ask them. That's what takes longer. I have done a study when we taught a new technique to a medical student, to a junior doctor, and to a senior surgeon. You know what? Whose learning curve was shorter? The medical student. Next was the junior doctor. The experienced surgeon took longer to adopt the new technique. So that's very obvious, which means we need to train our junior doctors in a slightly different way so we can overcome this learning curve. Again, next question is safety. Really? That's not true. When you're doing a robotic operation, you have got the full control. We have expert team, we have trained scrub staff, you have your backup ready, and not only that, what's the main worry for the surgeon? If you have to take an extra stretch, that's not a safe or unsafe operation, you can do it. What makes it unsafe, that in case of emergency, and what is the emergency, is the bleeding. Do we have control? We have less control when we are doing video assisted, but we have more control because you can actually put one arm for pressure to stop that bleeding area and dock it, and you can go and open the chest without being too much worried for any further blood loss. And what is true question is this cost. That is really true question. It is very expensive, no doubt about it. And what about the evidence? There is certainly no randomized controlled trial in the current era which can justify that robotic is better than this. There are studies going on at the moment, but there were some studies published which show that in their data that the robotic surgery had some advantages. And the recent rise in the thoracic robotic surgery and the robotic mitral surgery, I think, will probably generate some kind of evidence and hopefully some kind of randomized controlled trials. But what we need to look into this is, do we need to be early adopters or the late adopters? Do we need to sit for another 20 years or should we go on to this? Coming to Pakistan, Pakistani public, although poor, but they are very progressive people. This is a very progressive country. You're already doing minimally invasive